listeners.
Oh,
I'm so excited to just catch up with you
too.
and learn about your life and all of the things you've been learning.
I'm so excited. I heard you've been doing so much research.
Yeah,
tell me a little bit about it.
I have been. I've been researching this thing called electropalatography or EPG therapy, and it's really interesting because usually in speech and language therapy, the patient relies on auditory feedback, but with EPG therapy, the patient also has the advantage of visual feedback as well, which is really helpful.
So what is it exactly?
It is a technique for recording both the location and the timing of tongue contact with the roof of the hard palate during speech therapy.
Okay, can you tell me a little bit more about how it's used?
Yeah. The speaker actually wears an artificial palate that fits against their own hard palate, and it has electrodes embedded in it.
Interesting. So how does that enhance therapy specifically?
Yeah, so EPG uses specifically designed computer software to allow the speaker to view their tongue-palate contact immediately during therapy. So it's really interesting.
Okay, so what does the procedure look like for them?
Yeah, a custom-made, like I said, artificial palate is molded to fit against their hard palate. Then it's placed against their hard palate during therapy and connected to the computer software. While talking, the speaker can actually view directly their articulation information on the screen, so it is that immediate visual feedback.
That's really neat. So what are the applications from the therapy?
Yeah, so EPG has both research and clinical applications. In research, we can use the technique to find out more about the tongue itself and tongue contact patterns that both typical speakers and speakers with speech disorders make. So it helps us know a little bit more about the tongue contact, and it's been used obviously with a wide variety of speech disorders. That's where it's mainly used, most notably cleft palate and also functional articulation disorders, hearing impairment, and in adults with acquired speech disorders. For example, difficulty with speech following a stroke. So EPG can be used to help diagnose speech disorders, which in turn lead to a better, more efficient treatment. It's a useful tool for tracking progress and giving a clear representation of speech before and after therapy.
Wow, that's so interesting.
Yeah, it is. It really is.
Yeah. So are there any specific populations that benefit from this therapy?
Yeah, actually, specifically people with Down syndrome have been benefiting from EPG. It's really interesting. People with Down syndrome often prefer visual methods of learning versus an auditory method. So for example, children with Down syndrome find it easier to learn words when they're learning it visually versus with auditory information. So in the same way we can use the EPG with people with Down syndrome, they could find it easier to modify their speech when they're seeing it, and then instead of just having an auditory method. And it also is really helpful to help people that are hard of hearing as well because they can see their results. Yeah.
Interesting. That's very interesting.
Yeah. I want to hear all about what you've been doing too.
Yeah, so mine is kind of similar. It's actually another kind of visual feedback, but this actually uses an ultrasound machine.
Okay.
So it uses the ultrasound transducer that's placed under the chin, and that shows real-time images of the tongue. So you can see different sides of the tongue.
That's cool.
This information shows the client and the clinician information about the positions of the tongue as the person is speaking. And people like us, speech-language pathologists, can use these images to help their clients shape their tongues to better produce the sound.
Wow.
So it's really good, and it's really cool for lots of people to use.
That's really interesting.
So, so there's a lot of science behind it, which I'm really fascinated by.
Yeah. Tell me about it.
The ultrasonic waves from the transducer encounter the air in the oral cavity just above the tongue surface. And then these waves are then reflected back towards the probe.
Okay.
And then the reflection is displayed in dynamic images that show the shapes and locations of the tongue. So you can see it in different kinds of views. Yeah, it's really cool. So there's the mid-sagittal and coronal views of the tongue, which can be displayed by orienting the probe in a front-back direction, parallel to the side of the head or in a left to right parallel to the face. And then also the sagittal view displays images from the tongue tip to the tongue root, so you can kind of see the whole side of it. And the coronal view shows the relative height of the sides and midline of the tongue, and consequently any midline tongue grooving if there's anything funky going on, which can make reading the ultrasound a little bit confusing. Yeah. But typically people will use a sagittal view just because the sagittal views display relative backness, height, and slope of various regions of the tongue, when it's important to show the relative difference in height between the sides and center of the tongue. Then the coronal view is used.
Wow, that's so cool.
Yeah,
awesome.
So in a specific study in an urban setting, adolescents and young adults have actually shown faster gains in speech production training with the support of ultrasound feedback than with previous treatment without such feedback. So it really is, having really cool results.
Wow, that's so cool that your research led you to all of that.
Yeah, it's super interesting, but it's only specifically for certain sounds, which is kind of interesting.
Mm-hmm.
So it's only for T sounds, D, N, S, Z, L, R, K, and G.
Gotcha.
So that's kind of what it's specialized to.
Yeah.
So the procedure for this is really interesting. The speech lessons make an attempt to adhere to the principles of motor learning by incorporating, and then there's 3 steps to the procedure. So first is mini practice trials, which is approximately 200 trials within an hour-long session, which is typically how long they are.
Interesting.
Second is that they practice variability, so they practice more than one sound variant of each target. So they're trying to get a little bit of all the sounds.
Yeah.
And then third is reducing the amount of feedback over time, and then changing the type of feedback.
Gotcha.
So from primarily knowledge of performance to primarily knowledge of results.
Interesting.
Yeah, and then additionally, when it's incorporated into treatment, the ultrasound is not used for the entire session. It's actually only used for less than half of the hour-long session.
Okay.
So the rest is just regular therapy and stuff like that. So then as the speaker becomes more accurate, practice moves to higher levels of complexity, from syllables to monosyllabic words to multisyllabic words to phrases, and the amount of sound visual feedback is faded.
So talk to me about the effects of it.
Yeah, so there's not any known risks associated with the use of ultrasound imaging, even of the tongue.
Mm-hmm.
It does use sound waves, and so it's not any kind of radioactive anything that could be really dangerous or anything. It just uses frequencies that are much higher than our ears can hear.
Okay.
So the ultrasound can feel a little bit uncomfortable since it's placed directly under the chin, so it's a little bit of a funky position, but there are no harmful effects from it.
Interesting.
Which is really neat.
Wow, and what about the results?
So the visual feedback technology has been used as an adjunct within speech training programs that apply many traditional principles and practices. And so the number of sessions in which ultrasound has been used with people with speech impairments has varied from 4 to 14, depending on the study and the participants' needs. But ultimately, everything is very positive towards it.
That's so cool.
Ka, 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 ka. La, la, la. T, t, t.
Now let's just actually have you do a zzz. Okay, nice. Now, you're probably wondering, how are you going to ever get both sides up there? Guess what? Do it. Tut, 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 tut. Okay, can you bring it a little bit more forward? Okay, not a ta, let's just do it.
I don't know.
No, you're right, you're right. Okay.
Begin by positioning the participant comfortably in a chair with his or her feet on the floor, back straight, and chin slightly forward. Then, place a small amount of ultrasound gel on the ultrasound transducer. Next, position the transducer vertically, making tight contact with the skin underneath the chin and applying a firm but not an uncomfortable degree of pressure to collect a sagittal image and visualize tongue from tip to root. Check the screen to verify that the transducer is properly oriented such that the front of the tongue is on the right of the screen and the back of the tongue is on the left. Angle the ultrasound transducer slightly forward or slightly back depending on what part of the tongue is of interest. Instruct the participant to swallow to orient the user to the tongue position relative to the palate. Next, collect coronal images by rotating the ultrasound transducer 90 degrees to capture the tongue from the left to right side. Instruct the participant to sustain sounds requiring midline grooving of the tongue. After imaging is complete, wipe off any excess gel and clean the transducer with ultrasound-approved disinfecting wipe or spray. Begin by instructing the participant on the proper position of the ultrasound and allow them to hold the ultrasound transducer. In a sagittal view, observe the tongue between two major shadows created by bone, which is opaque to ultrasound, the shadow of the mandible and the shadow of the hyoid. Instruct the participant to produce alveolar and velar sounds such as T, D, N, then K, and G to help orient both the participant and the clinician to which side of the image is anterior tongue tip and which side is posterior tongue dorsum. In a sagittal view of a correct production of R, check to see that the anterior portion of the tongue elevates while the back part of the tongue dorsum slopes backwards. To assess distorted R production, instruct the participant to imitate and sustain the R sound. Then, have the participant imitate the R sound in a number of syllables, such as
ear, say ra, say re, say ru.
Finally, rotate the probe 90 degrees to obtain a coronal view and observe the lateral margins of the tongue as the participant repeats the syllables r, ear, ra, re, and ru. Position the probe near the highest point of the tongue, about 1/3 of the distance between the chin and the throat in the sagittal plane. Orient the participant to ultrasound images in sagittal section by asking the participant to point to the anterior and posterior regions of the tongue, or front of the tongue and back of the tongue, respectively. Teach the participant about the different parts of the tongue. Show the participant examples of good image quality and bad. Then, instruct the participant that R requires both an oral constriction in the front and a pharyngeal constriction in the back. Next, introduce the participant to different tongue shapes for the R sound using drawings, ultrasound images, or magnetic resonance images. Make it clear where the oral and pharyngeal constrictions are, but also acknowledge that every tongue shape is slightly different. Ask the participant to describe two major constrictions for R that are visible in a sagittal section. If the participant cannot identify the oral and pharyngeal constrictions just described, continue to instruct. Then, orient the participant to ultrasound images in coronal section. Instruct the participant of the desired tongue shape from left to right. Ask the participant to trace the tongue shape, identify the left and right edges, identify the center line groove, and explain the desired shape. Have the participant attempt to produce correct R in isolation or in syllables by providing phonetic cues to copy different tongue shapes. Then, ask him or her to provide an explanation of what they did correctly or incorrectly after some of the attempts. After the participant produces the correct sound, press the pause button to freeze the frame and discuss how this correct image looks different from previous incorrect productions. Finally, allow the participant to practice throughout the session without the ultrasound and offer the opportunity to successfully practice R without visual feedback. Here, a sagittal view of a magnetic resonance image during a correctly produced American English R with ultrasound image of the tongue is shown. Notice the elevation of the anterior tongue and the lowering of the dorsum. On the other hand, in this incorrect or distorted production of the American English R, notice the low tongue tip and blade and the raised tongue dorsum. This shows the mean accuracy on words containing R across 11 American English-speaking participants who were treated for R distortions. After 7 sessions of ultrasound biofeedback therapy, an upward trend in accuracy continues, suggesting that retention and generalization continued to occur.
While attempting this procedure, it's important to remember to check the positioning of the probe. Don't let the probe rotate or slide, or the images will become distorted and will be hard to interpret.
Following the use of ultrasound, traditional speech therapy should be included to encourage successful attempts at speech sounds without visual feedback.
Don't forget that ultrasound requires attention to safety, in particular disinfecting the probe between uses and also attempting to minimize exposure when possible.
After watching this video, you should have a good understanding of how to collect ultrasound images of the tongue and how to use this information to assess and provide feedback to patients about their tongue movements during speech.